So the second case that we're going to be looking at is that of Sheila. Sheila is 88 and has recently moved into the care home. She walks with a frame, but on trips out with staff, she struggles to walk further than 10 metres without getting breathless, so she uses a wheelchair. Today, while you're washing her, she seems more breathless than usual and is complaining of pain. Sheila's medical problems include heart failure, atrial fibrillation, which is a type of irregular heartbeat, diabetes, and mild cognitive impairment, which gives her a poor short-term memory. Her medications include warfarin, which is a blood thinner, ramipril and bisoprolol for her heart failure, and metformin for her diabetes. She has no known drug allergies. So given the information that I've given you about Sheila, what do you think might be going on? We're going to use the Is My Resident Well questions to make this assessment and find out how we can help her. So starting off with her breathing, this is obviously an area of concern because she appears to be breathless at rest. We know that in her background, Sheila can only walk 10 metres before getting breathless, but being breathless in her chair marks a change from her baseline and therefore is of concern. If we move on to the bowels, I can tell you that her bowels are a type 4 on the stool chart and therefore there doesn't seem to be a concern here. With hydration, she seems to be drinking enough and she's passed urine in the last few hours, and so again we're not that concerned about that. However, when we move on to assess her pain, this could potentially be an area of concern because she's complaining of being in pain. The first question that we need to ask is, where is it? Because a pain in the leg is very different to a pain in the chest, and Sheila tells you when you ask that she has chest pain. Given the fact that she has heart problems known already, this is especially more worrying for her in case this might represent a heart attack. Possible reasons for the changes we see in Sheila are a heart attack, an irregular fast heart rhythm like atrial fibrillation, a clot in her lungs, or a chest infection. At this point, someone with chest pain needs to have an urgent assessment, and the correct thing to do would be to call 999 rather than going through the rest of the assessment questions. And that's because if she is having a heart attack, she needs immediate medical attention. So according to Sheila's care plan, she is still going to be sent to hospital in emergencies, and so 999 is called and she goes in. After 2 weeks, Sheila comes back to the home but seems a lot frailer. The hospital letter tells you that she's had a heart attack which has weakened her heart. She's now breathless just while sitting in her chair, but does not need oxygen. While you're helping her to dress one day, you notice that she has some red skin on her heels. So now that we've noticed the red skin on her heels, it would be appropriate to use the questions again and make an assessment to check there's nothing else going on for Sheila. If we look at her breathing, we do know that there is a change in her breathing since she's come out of hospital, in that she's breathless at rest in the chair. However, this has become her new baseline or her new normal, and so right at this current moment, her breathing isn't a new concern. Moving on to her bowels and hydration, there are no new issues, and when we ask about pain, Sheila denies that she has any. She doesn't seem to be confused, and we're not overly concerned for her well-being at this point. However, skin has been highlighted as an area of concern. So in terms of assessing, we're going to obviously do a full body scan to make sure that there aren't any further red areas that could represent pressure sores. And then with the heels, you can use the finger test to see whether the redness remains or goes away. And obviously any redness that remains, particularly in a pressure area like the heels, is likely to represent a stage 1 pressure sore, and therefore things should be put in place to stop it getting any worse. So this might include special cushions under her feet and behind her heels. And it would also include trying to make sure that she's moving her feet around as much as possible for somebody who is essentially going to be sitting down a lot of the day. And finally, in our care for Sheila, this probably represents a good time to start thinking about her care planning and whether going back into hospital, if she should develop a further problem, would be the right thing for her. We can ask her because Sheila seems to have capacity to make these kinds of decisions, but it would be a good idea to talk to her family and to her about how she felt about being in hospital and whether she would want to go back in. And then we could update her care plan accordingly. If she hasn't already had it discussed, it would also be a good idea to talk to her about resuscitation and what she would want to happen in the event of an emergency if her heart and lungs were to stop working. And obviously a DNA, CPR, do not attempt resuscitation order could be put in place if this was felt to be the best thing for her. So hopefully these cases have shown you how we can use the "Is my resident well?" questions in real life, and I hope that these will help you in your work looking after your residents.